Hello, this is Dr. Chad Versio here from RUHS, the Chair of Pediatrics, and we are very lucky to have with us today Dr. Bryan Oshiro, who's going to educate us about the efforts that RUHS is taking to deal with maternal health, specifically with substance use. This was not entirely intended with April 20, but we thought this would be kind of a nice opportunity for everybody to learn about what the OB department has been doing to address the opioid epidemic. And so I'm sure some of you know Dr. Oshiro. Those of you that don't, you're going to have the delight of getting to know him a little bit better. He is one of our OB providers here and is our specialist in maternal fetal medicine. And one of the things that I really appreciate about Dr. Oshiro is that he's always thinking from a systems perspective. So not necessarily what the individual point of care at any particular time is, but much broader than that. And of course, you know, the individual touch points that we have with patients are heavily influenced by the systems that we have in place. And so he's, you know, visioning this not just for what is happening in our OB unit, but what is happening across the region for high-risk pregnancies so that we can improve the outcomes of children and mothers across our region. So I want to give a warm welcome to Dr. Oshiro. Very happy to have him here with us and looking forward to learning about what they're doing in OB to address the substance abuse problems across the country.
All right, thanks, Dr. Versio. Appreciate the introduction. You're too kind. Just wanted to discuss what we're doing here and a little bit of background. When I first came over to work at RUHS back in 2016, 2017, it was apparent that we had a lot of patients that were using multiple substances, but in particular, opioid use was very high in this area. And we just didn't have a concerted, organized systems approach to treating, screening for opioid use in pregnancy. There were other programs that are out there, and we'll talk about those as well. But there really wasn't a single point where somebody that had a problem could come in and get assessed both for their medical needs, their obstetrical needs, and get started on treatment and referred out. So as a background, somewhere around 15 to 20% of women are estimated to have filled an opioid prescription during their pregnancy. And this goes back to 2019 PRAMS data, which is a survey that's done by the CDC in multiple states across the country. In fact, I think it's on all states across the country. And 6.5% roughly of those women reported using opioid pain relievers during pregnancy. It was deemed that 20% or so were misusing these painkillers, and about another quarter of them, 27%, wanted to either stop or cut down. And interestingly, it was up to 31 to 32%, somewhere in there, that they reported that the providers really didn't provide any counseling on what the detrimental effects of opioid use was for their baby. And Dr. Versio, since he's intimately involved with kids, you know, he'd probably be surprised that nobody's talking to our moms, or a large percentage of our moms aren't really getting counseled properly. So say, you know, this is really not in the best interest of the baby and so forth. And furthermore, once they identify that, you know, is there a method to get them off? And what are some of the bad effects of opioid use during pregnancy? Well, these are some of them from a study that was done and published in the Current Psychiatry Journal in 2015, and it outlines preterm birth is higher with all sorts of medications, but in particular with opiates. We have preterm birth, small for gestational age, low birth weight. Of course, the infants may have cognitive and neurodevelopmental outcomes that are negatively impacted. And we all probably know about the neonatal abstinence syndromes, or the withdrawals of the babies from opioids and so forth. And we've had extended stays in our NICU more than a couple of weeks, actually. We've had one that was more than 4 weeks with withdrawal symptoms and treating the babies in our neonatal intensive care unit. So, you know, this is a really detrimental situation for babies to be in. And if you can imagine, these people, these patients of ours, they're not well off either, and they're really in a high risk, highly disadvantaged BIPOC population for sure. And then we're adding this on top of that. So the babies are really set up for not having a really great life. If you look at the rate of opioid related deaths, and you probably heard about this in the news, national news, is that opioid deaths have just risen over time. And that's no difference in California as well. And you can see by this data from 2010 to 2017 that you know, deaths in all ages really have gone up significantly over time. And now what we're seeing is synthetic opioids and fentanyl. And people even don't know that they're getting those products because those are laced in with marijuana and other substances as well. So they think that they're getting something else, and yet they're dying from you know, contaminated other meds and so forth. So this is just a heat map of the counties in California to say, you know, where are these deaths occurring? You know, we're not that high right here in the 2019 survey data, but we're actually seeing a lot. I mean, we have more in Riverside County than we do in San Bernardino, right next door. It's just a higher population. And when I was in Loma Linda, I really didn't see a lot of opioid or other substance use patients, really. Different demographic totally. We just have a higher risk population here at Riverside. So as I was mentioning, we didn't have a concerted effort. Nobody in the system, Riverside healthcare system, was actually able to prescribe buprenorphine. They didn't have an X waiver. So I decided, well, if nobody's going to do it, and I'm sort of the, you know, perinatologist for the hospital system, I might as well go ahead and do it. So back in 2017, 2018, I was the first one in the system to get an X waiver so that I can prescribe buprenorphine and provide MAT services to our patients. So we decided, you know, we're really going to be targeting the pregnant patients in particular that reside in Riverside County and they're Medicaid eligible. So that was our population, because that's really who we see in Riverside County at our hospital system. And we figured that because of their pregnancy, that all of them are really eligible for Medi-Cal. And so we looked at and said, well, where are the patients coming from? You know, a lot of them are showing up in the emergency room because of overdose, or they're brought in by law enforcement, or some of them are actually picked up by our navigators through the SU Cares hotline and so forth, and are recommended to come for visits in the hospital for detoxification. So since I'm also the medical director for obstetrics in the hospital and so forth, we set up a program and we discussed it with everybody. We just send them to labor and delivery. We have a pretty much standard way of treating withdrawals in these patients. So our nursing staff on labor and delivery are fairly used to it, and the residents, as they rotate through, are taught and so forth. But I usually oversee the management of the detoxification of the patients, and then the establishment of either buprenorphine or methadone. I highly recommend buprenorphine because it's easier to prescribe for me and to follow the patients out. And for if they go back to jail, for example, I'm able to easily get them prescriptions so that they can be managed at the jail with medical management. Some patients don't do well on buprenorphine and require methadone. So on occasion we'll do that, but it's tricky and it's harder because we actually have to make sure that they make their appointments to the methadone clinic and so forth. And if they go back to the jail, it's more difficult to coordinate those visits and arrange for transportation. But in any case, once we get them on a stable dose of buprenorphine, then we're able to then discharge the patient. And we take advantage of the hospital stay to provide all the prenatal care that they need. So a lot of them have not had a prenatal visit with anybody. Quite a few of them are actually homeless. And so we are able to provide social work services for them to get them situated. But we draw all of their prenatal labs. We do a dating ultrasound. We look for birth defects, and we get a contract going with the patients and so forth if they're so motivated, and either provide them with the services that our SU Cares team provides, and in particularly in inpatient realm, April, who's leading the charge on the inpatient side from social work services, and in the next day or so, we can usually get a bed within a week. So I have the luxury of being able to hold them in the hospital until that happens. And many patients are happy to just stay until that takes place. And so we don't want them to go out and go to a temporary spot like their mom's house or someone's couch or even a home, and then have the temptation to use before they can get into residential treatment. And we use the treatment centers that are in the community. So we try to be collaborative in that way. And then probably half the patients, we use their outpatient services. So they're not residential, but they're outpatient. In those cases, I'll usually continue the MAT therapies and so forth. If they get into residential, most of the times they've then take over the MAT treatment for those patients. And then we establish prenatal care visits with them. If they live fairly close and don't have transportation, we try to provide transportation if they don't have that. Or if the services are out in Palm Springs or Indio, then the OB care is provided by someone else. And even in Riverside City itself, there's a residential treatment center there, and they prefer to use their own OBGYN that's there. But for the most part, the patients are happy to come back to us and so forth. So they find that they're a little bit high risk, and they have other mental health disorders that we're able to help them with. Everybody that is eligible for home visitation programs from the Riverside County Health Department, from the Nurse Family Partnership or whatever programs that we have, we try to get them in there too, so that they can assist and make sure that they're eligible for these other programs. And then we have usually two graduate students, master's students or PhD students in behavioral health embedded in our clinic 2.5 days a week. So they'll come over and see the patients as well. And like I said, Lynn Basso sees every single patient that comes through our clinic. And she also does the plan of safe care with them. So that assists them in case they have to go and see child protective services for whatever reason and so forth. So they have that plan of safe care there so that they can show evidence that they've been following all the required and necessary hoops and things that they have to jump through and stuff, and they're making a great effort. So some of the things that in particular, like I said, we do the OB evaluations, the detox, the SU Cares consult, case management consult. So all of these things are talked about and so forth. And we also offer visits with the neonatologist and just to outline what the care for the baby looks like. And then we've also have a monthly meeting, and we involve pediatrics in that because there's another pediatric program that looks at follow-up care and social work, follows up with the baby and so forth. So there's another handoff that's made with pediatrics on some of our babies. So what we try to do is really the service integration. Like we talked about, is that there really were disparate pieces of this spread throughout the county, mainly in behavioral health and in the county public health arena, but we really didn't have any central area where pregnant patients could come and get all this care together and so forth and organize it. So we become that hub. So we try to organize a system that really incorporates all the resources that we have in the county in a much more, I guess, effective way, you might say. And for sure, these are some of the things that we do: planning for delivery and postpartum, who's going to be there, what the care is going to be, and including some people who want to decrease the amount of buprenorphine that they're taking during the pregnancy and wean themselves off if in some certain circumstances and so forth. So I meet with them at least every 2 weeks. And we'll have calls in between as well if they need to and so forth. So we keep close tabs on them, and we follow their, medical, use as well and so forth, as far as their health screenings and their prenatal care. So it's all consolidated with us. So once they're delivered, we don't let them go. We make sure that during the delivery process that we're there for them. We guide the type of analgesia that they're eligible for. And we're able to not only take care of them in the inpatient arena, but even afterwards, we follow them out so that after they go home, we keep managing them until they're able to transition off until for their postpartum care and so forth. So again, this is sort of a consolidated, pretty well rehearsed recipe for us now. But the patients have been very satisfied. We have several now that I've contacted to act as a peer support, and they're willing to do that. So that's the next phase that we're going to be doing, is developing a peer support program, utilizing the patients that have actually gone through the program. So we've even had discussions extensively with jail patients and so forth, and the jail, so that they're not lost to care. It's a little bit more difficult because a lot of times these patients don't necessarily want to continue care, and some of them are homeless and so forth, and many of them live far away in Indio, Palm Springs, and beyond. So it is difficult. But while they are incarcerated, we're in touch with the jail nursing staff and so forth, and they do make appointments to see us on a regular basis for prenatal care. So these are some of the things that we try to address for each and every patient. So we're very non-judgmental, and that's really been, in fact, yesterday we had a patient that was addicted to Norco after a knee injury, and she's been on it for 3 years, and she just got pregnant, and she desperately wanted to get off, and she tried 3 times before she saw me. She's still in the first trimester, and she had violent withdrawal symptoms. So she actually, through a friend of hers, was able to get a hold of some buprenorphine. Her husband found out about it a couple of days before our visit, and was very upset with her and said, you shouldn't be doing that without being supervised by a physician and so forth. But she said, I got to get something because I want to get off the Norcos. And she didn't know we existed. And then lo and behold, someone called her and someone called us and said, we have this person out there and she needs your services, and referred her. And we called her, and she was excited to see us. And I spent 2 hours with her yesterday and so forth. And she has a myriad of problems. So we're taking care of all her multiple needs, including her knee injury, her psoriasis, her hypertension, her prediabetes, in addition to her pregnancy and her addiction. So we have a perinatal nurse, care manager that takes care of our patients and so forth. So she, in conjunction with Lynn Basso, will be following up with this patient. And most likely we're going to get her into residential treatment as well. So more to come on that. But there's other drivers that we're figuring out. These patients have other issues with social determinants of health. And so looking at food assistance and transportation and stable housing is very, very important for the success of this program and so forth. So, we don't have all the pieces, but we're slowly getting them together. So we are applying for another grant to get some of the other pieces. And in fact, another potential grant came in for us to apply to with American Heart Association that we're trying to get resources for not only substance abuse, but perinatal mood disorders as well. So we're going to try to integrate that. So another program that's been out in the county is the Moms Perinatal Program. So I don't want to sell them short to say we don't have any programs, but the Moms Perinatal Program preceded us. It's been administered by and in conjunction with behavioral health and public health nursing and so forth. But it's a wonderful program. They provide transportation for women and, and children under 5, and they provide medical screening and treatment if necessary and so forth. So there's a lot of support for these moms through that program as well. So we're aware of these programs, and what we've done is we meet every month. And in fact, sometimes we've met every 2 weeks to try to keep everybody on the same page and funnel the resources as necessary and interconnect and interlink these programs and services are available throughout the county. So once we get this up and running a little bit more and we can maybe utilize our telehealth programs a little bit more, we plan on expanding this to even the low desert out in Palm Springs and Indio, because I know we have some of these clinics out there. And simultaneous to this, we're also running a telehealth, perinatal telehealth clinic. We've rolled out to 5 clinics in the past year and a half. We're going to go to Palm Springs later this summer. We plan on adding 2 more clinics in 2023. And we're in negotiations to go out to Blythe with telehealth. So this program doesn't necessarily have to have, us see everybody, and everybody doesn't have to come see us in person. So that's the hope, is that through telehealth and partnering with local physicians and local programs, that we can really reach moms outside of our system and outside of our catchment basin. Okay, that's the presentation in a nutshell. I know there's a lot of stuff we talked about, and I talk really fast, but I'm really excited to talk about our program.
Thank you, Dr. Oshiro. It really is amazing to see kind of the comprehensive nature that you put together for this program. One of the questions I have is, of course, kind of a rough estimate of how many patients you're treating and following, and what capacity for growth do you see? And then the second thing is, what, in being cognizant of HIPAA, but what kind of challenges or difficulties come up through the process of treating these patients, and that kind of thing?
Yeah, so we don't have a good number on the number of patients that are eligible. But if you look at the data from this region and national data, somewhere between 5 and 10% of pregnant women have some sort of addictive exposure and so forth. So there's 35,000 deliveries in Riverside County every year on average. So if you think about 10% of 35,000, so you're looking at somewhere around 3,500 or so, or a little bit more than that. And that's a lot of women. There's no way we can absorb, 3,500, and they don't all need MAT services or residential programs either. But there are a lot of women that we're seeing. As far as what are the challenges and what are the capacity issues, we're able to handle many more patients than we're handling now. And if we could streamline this a little bit more and organize our telehealth program, I think we can expand that so that, I don't have to do all the, management stuff, and we can have, we already have protocols pretty much outlined and stuff. So we could disseminate that through the county so that even local OBGYN in conjunction with our help can do that. And as far as what are the pitfalls and hurdles that we've encountered and patients have encountered, logistics, a lot of logistical issues. Patients are sometimes without any transportation available, and so they can't get to us, or mental health, coexisting mental health disorders that make it challenging for them to really want to, and they're so used to using drugs as a crutch for them and so forth. It's really hard. And, if we can't get them out of their environment that they're at, it's really hard because all their friends are using it, their family. I mean, I had one patient who said, I had to move out of my house, get away from my family, because all my families are addicted to substances and so forth. It's really sad. So she had to separate herself from her own family and so forth.
Wow.
Yep. So yeah, there's a lot of hurdles that we see all the time.
Yeah. So it sounds like some work for Nicole and Leslie and our marketing team for making sure that people across the county are aware of these services that we offer. So hopefully we can have some billboards on the 10 for this service. And then Dr. Jukaku asked a very important, relevant question. Do you have issues with the use of marijuana and buprenorphine? And how do you kind of address that?
Yeah, so I personally don't have any problems with marijuana usage and stuff. So, because I don't really know, I don't smoke marijuana myself, so I haven't had a problem with that. But just taking buprenorphine, just taking marijuana by itself, marijuana is actually a big problem because now that it's legalized, we're seeing more patients with marijuana that use. Now there's more data coming out of the long-term effects, behavioral effects, and Dr. Versio, that it's not a benign thing because it does affect your brain. Well, if you think you're taking that in while the brain's developing, there is going to be some effects, and we do see that. So we highly recommend and ask the patients to stop marijuana usage, when they are pregnant. And as far as that and buprenorphine, really, when we counsel patients, they stop the marijuana use. So I haven't had patients that have continued marijuana and on buprenorphine.
Okay, thank you. Yeah, it definitely the long-term outcomes, as you said, that marijuana seems to affect development, cognition, and so. I think one of the challenges that I've noticed, as you mentioned, with marijuana being legal, is that it seems to be one of the effective things for severe hyperemesis. And so, seeing a fair number of patients that are coming in just using it for that particular purpose, because they otherwise, aren't able to keep anything down. And wondering, I guess this is a little bit off topic, but has CBD that doesn't contain THC, is that been useful anecdotally or
I don't know. I haven't looked into it myself, but we've been fairly effective in the medical management of patients with severe hyperemesis. So just as an aside, we had a patient recently admitted to the hospital last month. She hadn't eaten in 2 months. She lost weight from her initial 95 pounds of pre-pregnancy weight down to 82 pounds. She really, and so we got referred this patient because the health plans got involved and said, this is no good. We need to refer this patient out to a high risk specialist. So she was on home TPN, fortunately. So that's what was saving her, but she hadn't touched anything in 2 months. She said, every time I try to eat something, I throw it back up. We hospitalized her. It took us 2 weeks to get her medically managed. But by the time she was discharged, she was able to eat for the first time in 2 weeks, 2 months. So I've seen her once as an outpatient already. She's doing much better. She's gained back her weight almost. So she's now 92 pounds. So she's close to her pre-pregnancy weight. So I don't think that we really need to rely on CBD or any other, marijuana products and stuff.
Thank you. And then Dr. Jukaku asked a question about, and anybody else feel free to ask any additional questions. Do patients get any financial incentives to show up for appointments or take their medications to stay clean in the program?
No, we haven't done or needed to do that. The patients that stay in the program, they're very motivated. Just to tell you how motivated they are, I have one patient driving out from Blythe. I have another patient from Indio, and I had another patient that was up in 29 Palms area. Joshua Tree and they drove out here to see me just for medical management of their opioid use disorder. So it's been amazing how dedicated they are. They said, no, we're just going to come back and see you. Because I said, well, there's a program out in Palm Springs and you can, like we can refer you out there and you can see another obstetrician. And they said, we're not having it, just come over here. We're very comfortable.
Yeah, well, that's awesome. All right. Well, I think that's all we have time for today. Really appreciate your time and energy, Dr. Oshiro, and your commitment to the patients of Riverside County. This is something that I think really impacts that individual patient, obviously, but then impacts their child and then subsequent generations. And so, I think this is such an important thing for our institution to be offering.
Yeah.
All right. Hope everybody has a great afternoon. Thank you.
Thanks. Bye.